Hey there, everyone. It's Naveen Nathan, Assistant Professor of Anesthesiology at Northwestern University. This is going to cover renal and urinary systems and electrolyte balance. It's part one of a three-part series for the ABA Part 2 Advanced Exam. For whatever reason, the ABA sort of placed renal disease and end-stage renal disease, renal insufficiency management in the advanced exam, even though I fully think this is something that you would have learned and mastered as a CA1. Furthermore, they do want you to be aware of renal replacement therapy concepts, and so that's what we're going to cover in this lecture. So you are well acquainted with the end-stage manifestations of renal disease, which include, but are not limited to, anemia, of course, anemia of chronic disease, largely due to the lack of erythropoietin release from the diseased kidneys. Okay, uremic encephalopathy can occur due to the buildup of unexcreted toxins and metabolic byproducts. Decreased platelet adhesiveness, which leads to bleeding tendency, thought to be due to alterations and decreases in the release of von Willebrand's factor and factor VIII. So it's an effect that ultimately affects primary hemostasis, as opposed to coagulation abnormalities which occur in hepatic failure. So renal failure is in some ways worse because it really sort of affects the hemostatic process right at the onset of the platelet plug formation. Hypotension can occur from impaired vascular compliance, especially post-dialysis. Of course, since the kidneys are responsible for regulating electrolytes, these patients have a hard time regulating their potassium, and the patients can get hyperkalemic as well as hypermagnesiemic. Metabolic acidosis often develops due to impaired proton excretion. And renal disease is often coexistent with essential hypertension and arterial wall stiffening, and oftentimes with diabetes as well. So all the following will increase in patients with chronic renal failure, except which one? A, sulfate, B, sodium, C, phosphate, and D, magnesium. Well, sodium is the correct answer. Sodium actually declines overall. You tend to see a relative hyponatremia in end-stage renal disease. In some ways, that's reflective of the dilution of sodium with the excessive water retention that occurs in renal failure because the kidneys fail to excrete that water. But there's also an absolute reduction in sodium with end-stage renal disease that's been characterized as well. So uremic syndrome, affects a lot of things, not the least of which include water homeostasis, and you tend to see an extracellular fluid expansion. These patients develop a significant amount of edema and anasarca. As I mentioned earlier, they can get hyponatremic, but virtually everything else goes up in concentration. So you get hyperkalemia, hypercalcemia, hyperphosphatemia, hypermagnesemia, and a metabolic acidosis. Now, overall, it's hard to predict what will happen with calcium. You can get hypocalcemic because, of course, the kidneys regulate the activation of vitamin D and vitamin D-mediated calcium resorption. So because of that, it's hard to say exactly where their calcium levels will be. They can be either hypercalcemic or hypocalcemic from renal-induced osteodystrophy. Of course, huge impacts on cardiovascular function, leading to heart failure and hypertension and pericarditis due to the development of fluid around the pericardial sac, and dysrhythmias due to electrolyte dysfunction. These patients, as I said, are prone to edema, including pulmonary edema, and can have a central hyperventilation, ultimately resulting from that acidosis, very likely. The endocrine system is also affected. As I mentioned earlier, renal osteodystrophy can occur. Patients can be hypocalcemic. It's oftentimes decreased glucose tolerance and a hypertriglyceridemia with increased rates of atherosclerosis, which are often coexistent with renal disease. Renal disease patients, end-stage renal failure patients, present with delayed gastric emptying frequently. With anorexia, they can have nausea and vomiting, acute renal failure. And upper gastrointestinal tract inflammation and hemorrhage. As As I mentioned earlier, these patients are frequently anemic, and there's a platelet hemostatic effect, likely due to the reduction in von Willebrand's factor and factor VIII. From the neuromuscular standpoint, these patients can develop encephalopathy, seizures, and tremors, as well as myoclonus, again, likely due to the alterations in acid-base balance and electrolyte composition. These patients may have sensory motor polyneuropathies and a significant degree of autonomic dysfunction. If you've ever taken care of someone with end-stage renal disease, you know they are all over the map in terms of their blood pressure response to anesthetics and volume. So chronic renal failure patients have glomerular filtration rates less than 25% of normal. That's pretty much the definition of renal failure. Metabolic acidosis also occurs in a variety of different forms in end-stage renal disease. There's a hyperchloremic form with the normal anion gap acidosis, and a high anion gap acidosis from the inability to excrete titratable acids that you typically don't measure. But ultimately, these patients are acidotic. Hypertension is almost a universal finding due to extracellular fluid volume expansion and an adaptive response to that volume expansion. The arteries tend to stiffen. There's autonomic factors like a constitutive increase in circulating catecholamines and hyperrenanemia, which is a huge factor here in the coexistent state of hypertension with renal failure. Remember, hyperrenanemia will ultimately lead to hyperaldosteronism and the chronic retention of sodium in water. Myocardial dysfunction, heart failure, oftentimes things you have to think about as possibilities when treating the end-stage renal failure patient. Pericarditis, actually relatively common with end-stage renal disease. It can be secondary to the uremia or even to dialysis therapy, depending on how much fluid and electrolytes get changed through a dialysis session. Tamponade may develop in upwards of 20% in that latter group. Pulmonary edema and restrictive pulmonary dysfunction occur, largely due to hypervolemia. As I said, you see a common theme here with a lot of retention of interstitial fluid. May result from heart failure as well, and the reduced serum oncotic pressure and increased capillary permeability. The pulmonary edema is actually responsive to dialysis, thankfully. So anemia of chronic disease, largely due to reduced levels of erythropoietin and red cell damage. Ongoing gastrointestinal blood loss can occur, and of course iron or vitamin deficiencies that may coexist with this. Platelet dysfunction, ironically, is actually responsive to dialysis. You can treat platelet dysfunction with cryoprecipitate, which contains appreciable levels of factor VIII and von Willebrand's factor, as well pharmacologically with desmopressin or DDAVP, which releases factor VIII and von Willebrand's factor from the endothelial cells. Acquired defects in cellular and humoral immunity ultimately places renal failure patients at risk for infections more so than healthy patients. And there's a pretty high mortality from sepsis that develops in a patient with renal disease as they already have one organ system down. So which of the following is indicative of pre-renal cause of kidney failure? And this is pretty much directly from a previous ABA exam. And your choices here include fractional excretion of sodium greater than 1, plasma BU endocreatinine ratio of less than 10, urine osmolality less than 300, or urine specific gravity greater than 1.018. So the correct answer is D, urine specific gravity of greater than 1.018. That is most likely caused by an intrinsic cause of renal failure. Okay, and this table is from Harrison's Manual of Medicine. I think it's worth spending some time looking this over and committing some of this to memory. For all these keywords that we are creating lectures for, you could easily double, triple, quadruple the length of all these lectures and be exhaustive about all the information. And I try to focus on, the areas that you should definitely remember without getting too much into finer details that are less statistically likely to be tested. But I do throw in questions that are eerily similar to the questions that you would have seen on prior exams, and so that helps sort of refocus your energy, and especially in areas where, the ABA seems to come out of the woods with really weird questions that you would kind of scratch your head thinking, well, why would I ever have thought to study that sort of thing? And sometimes the questions are actually pretty straightforward. So take some time and look over this table. I don't think you need me to sort of go through it line by line, but it's worth sort of making your own mnemonic or whatever you need to sort of keep this in check for the advanced exam. So overall, managing renal failure, this is probably something that you understand thoroughly because you've been taking care of these patients since you were a first-year resident. 5% of hospitalized patients experience renal failure, resulting in greater than 50% mortality. So it's worth knowing how to manage these patients, especially since many of them will need to come to the operating room for a variety of reasons. Obviously, it's all about maintaining adequate renal oxygen delivery. And remember from the Part 1 exam that the renal medulla is most at risk because it does most of the work with the least amount of blood flow. So, ways to do this. So even though classically people have used dopamine and phenolapam to increase renal perfusion, okay, these essentially show an effect of diuresis, okay. They keep the renal tubules flushed with fluid and volume, and they increase urine output, but they don't necessarily have a proven increase in benefit or mortality overall. That's why these have really kind of fallen out of favor as standard of care for managing patients at risk for renal insufficiency or renal failure. Okay, but that being said, it is much easier to manage a patient with non-oliguric renal insufficiency or renal failure compared to someone with oliguria. From that standpoint, at least, it does ease the process of management. Mannitol has been described to have a protective effect on the kidneys if it's administered in the setting of pre-ischemic renal insult. Okay, it does this in a variety of ways. It's a free radical scavenger. It increases the production of renal prostaglandins, which vasodilate the capillaries in the renal tubules. And it's an osmotic diuretic, which means that it can keep the renal tubules flushed with fluid, with water, and acting as an osmotic diuretic. So it essentially keeps the fluid within the plumbing and avoids creating a hypertonic sludge of filtrate going through the kidneys. So for those three reasons, mannitol is used and has been shown to have proven benefits, primarily in one setting, and that is in renal transplantation. That's where it is actually indicated. Loop diuretics have a renoprotective effect, interestingly. They ultimately reduce the overall renal workload in the loop of Henle. And remember, that's the part that works the hardest. And that's where they exert a beneficial effect. N-acetylcysteine, it can be administered to have a renoprotective effect, particularly in the setting of infusion of intravenous contrast dye. And so there is a perceived increase benefit to using Mucomyst, or what's known as acetylcysteine. We're going to finish up with renal replacement therapy. So about 70% of patients with acute renal failure will require some form of renal replacement therapy. The top indications are volume overload, encephalopathy, hyperkalemia, and metabolic acidosis. So hemodialysis is distinct from hemofiltration. I just want to spend a little bit of time just covering the definitions of these two before we wrap up. Hemodialysis removes solutes by diffusion, which is driven by the concentration gradient of the solutes across a semipermeable membrane. Okay, blood and dialysis fluid are driven in opposite directions across a diffusional barrier, which is the dialysis membrane. You essentially have a countercurrent exchange of electrolytes and fluid. Okay, a large bore double lumen vascular catheter is required to do this. Okay, the advantage here, it's rapid. The disadvantage is you do get large scale volume shifts and significant hypotension in this process. Hemofiltration uses convection, not diffusion, for solute transport. So what's happening here is that a solute-containing fluid is driven across a permeable membrane, and by exerting a pressure difference across that membrane, you create what's called solvent drag. Okay, so it's not diffusion, direct diffusion. Because the removal of solutes by convection is relatively slow, hemofiltration is performed continuously. Okay, so it's a pretty slow process. The advantage is you get much less risk of hypotension compared to hemodialysis, since it's driven by pressure and not flow. Okay, so this is what we're talking when we talk about continuous arteriovenous hemofiltration, methodologies of that sort. Okay, removal of waste is a lot more gradual and physiologic. So you wouldn't do this for someone with life-threatening hypervolemia or encephalopathy or hyperkalemia. Okay, this is for more gradual management of electrolytes and acid-base balance. So overall, the disadvantage, you can't really use this for patients that are currently hypotensive. In that setting, you don't want to affect the arterial side of circulation. So in that setting, you have to use veno-venous hemofiltration, so CVVH, in that scenario. And again, another disadvantage is you can't treat life-threatening consequences of renal failure with this method. So that's part 1 of 3 parts that deal with renal disease and anesthesia for the advanced exam. So, thanks.